Let's dive straight into the updated 2025 and 2026 AHA and ESC guidelines for managing hypertensive emergencies in acute stroke during those critical first 24 hours. If you're an ED doc, an internist, or running the ICU, these newly published thresholds directly impact your daily practice.
Here's our clinical roadmap for today's Shift-Ready Explainer. We'll start by defining the hypertensive emergency concept, split off into ischemic versus hemorrhagic stroke targets, break down acute medication administration, cover patient disposition, and finally leave you with the official bibliography.
Section 1. The hypertensive emergency concept. First up, we've got to be crystal clear on what we're actually treating and, honestly, what we aren't.
So, per the 2025 AHA and ESC guidelines, a true hypertensive emergency isn't just a scary number on the monitor. It requires acute target organ damage right alongside a blood pressure over 180 over 120 millimeters of mercury. That specific combination is what absolutely mandates immediate intervention with parenteral therapy. We're talking about a critical condition here that affects about 1 to 2% of hypertensive patients, usually driven by autoregulation failure and endothelial dysfunction.
And here is a massive update you need to pay attention to: a Class 3 harm designation. The 2025 guidelines explicitly warn against just throwing intermittent IV antihypertensives at asymptomatic severe hypertension. Why? Well, spontaneous blood pressure drops actually happen in 40 to 50% of these patients without us doing a single thing. Aggressively treating just the number without organ damage is strongly linked to acute kidney injury, longer hospital stays, and even higher in-hospital mortality. So hold off on treating just a number.
Section 2. Ischemic stroke BP targets. Now, let's take that first fork in the road based on our neuroimaging, the ischemic stroke pathway.
For acute ischemic stroke, your blood pressure targets hinge entirely on your reperfusion strategy. Getting ready to push IV thrombolytics? You need that BP carefully lowered to below 185 over 110 before you start. Heading to endovascular thrombectomy? Same deal. Maintain that strict 185 over 110 or less threshold before the procedure. Now, if they aren't a candidate for reperfusion therapy at all and they're sitting way up above 220 over 110, the strategy totally shifts to a super cautious, slow reduction, dropping it by only about 15% over the first 24 hours. But once you've given reperfusion therapy, like IVT, the goalposts move. You now have to aggressively hold that blood pressure below 180 over 105 for the next 24 hours. This is absolutely non-negotiable to prevent hemorrhagic transformation or reperfusion injury in that fragile, newly opened vascular bed.
And this next part is fascinating. It perfectly shows why we don't just tank the pressure to normal levels. Recent data, like the Enchanted-2/MT study, prove that intensively driving the systolic below 140 actually makes global disability worse after a successful EVT. They literally had to stop trials early because functional outcomes were getting so bad. For post-IVT patients, dropping it below 140 shows zero clinical benefit. So driving it below 140 is now a strict Class 3 recommendation for harm in the EVT crowd.
Section 3. Hemorrhagic stroke BP targets. Let's take the other fork in the road and look at our acute targets for intracerebral hemorrhage, or ICH.
The 2025 European Stroke Organization guidelines really emphasize speed here. For minor to moderate ICH, you ideally want to start antihypertensive therapy within the very first 2 hours of symptom onset. Time is brain, and we need to stop that hematoma from expanding.
For ICH, we're really looking for a Goldilocks zone. Yes, you want the systolic below 140 to effectively prevent expansion, but you have to avoid the danger zone. You absolutely cannot drop the systolic by more than 70 points from their baseline, and never, ever actively push it below 110. Plunging it too fast or too low totally wrecks their cerebral perfusion.
So it's not just about the target number, it's about how smoothly you get there. The updated AHA guidelines hammer home the need for steady, non-labile control. Post-hoc analyses of major trials have shown a direct linear link between blood pressure bouncing around in that first 24 hours and severe disability or death at 90 days. Riding a blood pressure roller coaster between peaks and troughs is quite literally just as dangerous as the initial hypertension itself.
Section 4. Acute medication administration. So how exactly do we safely achieve these super strict parameters? Let's talk about the specific drugs you should be reaching for.
The 2025 AHA guidelines point us to first-line IV agents like nicardipine, clevidipine, and labetalol.
Nicardipine drips usually start at 5 milligrams an hour and titrate up pretty easily every 5 minutes. Clofidipine is crazy fast, starting at 1 to 2 milligrams an hour and doubling every 90 seconds. Labetalol is your standard option for slow IV pushes, usually dosed between 0.3 and 1.0 milligrams per kilo.
Now, while the guidelines are clear that there's no single high-quality RCT crowning one drug the absolute universal winner, the clinical data definitely leans toward nicardipine being much more effective than labetalol for hitting those tight targets smoothly. And clevidine, it acts even faster. Ultimately, your choice depends on the patient's specific comorbidities, but generally speaking, continuous infusions are going to give you that smooth ride we desperately need.
Section 5, Disposition and Home Messages. Let's wrap up with what this means for patient disposition and your key takeaways for your next shift.
Listen, every single patient with a true hypertensive emergency in the setting of acute stroke needs immediate ICU admission. Period. It's a Class 1 recommendation. They need continuous hemodynamic and target organ monitoring. There are no exceptions here. These patients require the highest acuity bed you've got in the hospital.
So, to quickly recap your main takeaways. Number 1, don't treat a severe number unless there's true acute organ damage. Number 2, strictly separate your ischemic and hemorrhagic pathways. For ischemic, stay under 185 over 110 before reperfusion, under 180 over 105 after, and whatever you do, don't tank it below 140. For hemorrhagic, aim below 140, but do it smoothly, no massive drops over 70 points. Number 3, rely on titratable IV drips like nicardipine or clevidipine, and finally, secure that ICU bed.
Section 6, AHA and ESC Bibliography. For the protocol writers out there, here is the source literature driving these pathways.
These updates are pulled straight from the newly published 2025 and 2026 AHA and ASA guidelines, as well as the comprehensive 2024 ESC and 2025 ESO documents. This is literally the cutting edge of cardiovascular and neurocritical care.
So I'll leave you with this. Before you clock in for your next shift, ask yourself, are your hospital's current acute stroke order sets and the default alerts programmed into your EMR actually aligned with these freshly published 2025 and 2026 evidence-based targets? If they aren't, it might be time to start a conversation with your stroke committee. Thanks for tuning into this explainer. Stay focused and keep learning.